Mapleson Breathing Circuits. Please like and subscribe. Mapleson's landmark paper in 1954 classified anaesthetic breathing systems into 5 groups, A to E, the aim of which was to deliver oxygen and anaesthetic agents to a patient and removing carbon dioxide during general anaesthesia. There are 5 key components: fresh gas flow input, an APL valve, tubing, a bag and a mask. The APL valve is a one-way adjustable spring-loaded valve with 2 key functions. It allows removal of waste gases and also limits the pressure in the system. The tubing is large internal diameter, non-kink, to enhance laminar flow and reduce resistance. The collapsible bag comes in 2 sizes, adults and pediatrics, with 3 key functions. It acts as a gas reservoir for fresh gas flow. It allows you to observe the breathing pattern of the patient. And finally, it limits the pressure within the system to 40 centimeters of water. Laplace's law suggests the pressure falls as the radius increases. And finally, the mask. The Mapleson systems have advantages and disadvantages. The advantages include its simple, low cost, they can be cleaned, and there's no toxic product production. The tubing can be increased in length in the form of Mapleson D to allow use in the MRI and its low resistance. The disadvantages requires high fresh gas flow and therefore increase the risk of pollution and also loss of humidification. And some systems are difficult to scavenge, and there's a risk of dilution from the atmosphere in Mapleson E. Now let's look at the basics of the system. There's 2 key points. The efficiency of the system will relate to if the patient's breathing spontaneously or being intermittently ventilated. And second of all, it's important to remember that fresh gas flow enters the circuit at all points through the respiratory cycle. There's 3 key points: inspiration, expiration, and the expiratory pause. In this example, we'll look at the Mapleson A circuit during spontaneous ventilation. So first of all, the patient inhales. This will remove fresh gas from the tubing and the bag, and this may result in the bag collapsing, which suggests the patient is taking an inspiratory breath. Next, the patient will exhale. This will result in the tubing and even partially the bag filling with a combination of exhaled dead space gas, whilst new fresh gas enters the system. Once the bag is full of gas, the pressure within the breathing system will start to rise and the expiratory valve will open, allowing alveolar gas, which contains carbon dioxide, to be vented from the system. The final phase is the expiratory pause. More fresh gas flow enters the system, driving any remaining alveolar gas within the tubing to move out via the APL valve. If the fresh gas flow is sufficiently high, all of the alveolar gas will be vented from the circuit before the next respiratory cycle. However, if the flow is not sufficient, there's a risk of rebreathing. In 1954, Mapleson described 5 key breathing circuits, A to E. As 6th circuit, the Jackson-Rees modification of the Ayres T-piece, Mapleson F, was later added in 1975. Coaxial versions exist for Mapleson's A and D. Mapleson A is most efficient during spontaneous ventilation at 70 ml per kilogram per minute. Conversely, Mapleson D is the most efficient during IPPV at 70 ml per kilogram per minute. The features of the Mapleson A system. The APL valve is close to the patient and the tubing is between 110 and 180 centimeters. This results in an internal volume of at least 550 ml. However, the dead space is too great for children under 20 kilograms. And the disadvantage of this circuit is due to the heaviness of the APL valve close to the patient end. The well-known Mapleson C circuit or the water circuit is used for resuscitation due to the low dead space. Conversely, the Mapleson B is the same as that of the Mapleson C, but it's longer. Both these circuits are inefficient, but B is more efficient, secondary to the corrugated tubing acting as a reservoir. Mapleson E, or the Ayres T-piece, was introduced by Philip Ayre in 1937. It's 1 cm by 5 cm long and is used as a non-rebreathing circuit. Fresh gas flow enters the system and the reservoir limb volume should not exceed tidal volume to prevent inhalation of room air. During spontaneous ventilation, the expiratory limb is open to atmosphere. However, during IPPV, intermittent occlusion of the expiratory limb can occur. The advantages: it's compact, it's cheap, it's valveless, and it's low resistance in dead space. However, it requires a high fresh gas flow and there's no scavenging. Mapleson F. This is a valveless system suitable for both IPPV and spontaneous ventilation in patients less than 25 kilograms. The 500ml bag attached to the expiratory contains a hole which can be occluded to control ventilation. However, scavenging is not possible with this system. Two coaxial versions exist. The LAC, which is a coaxial of Mapleson A. It is similar in function to Mapleson A, except the expiratory valve is close to the anaesthetic machine and thus enhances the ability to scavenge. The Bain circuit, which is a coaxial of Mapleson D, produced by James Bain. It's 1.8 metres long with an internal volume of 700 mils, outer diameter of 22 millimetres. The disadvantage: if the inner tube becomes disconnected or malfunctions, this can result in an increase in dead space and severe hypercapnia for the patient.